cataracts in children, helped by Dr. Orlando. Dr. Mundia will be taking us through tonight's CME. Thank you so much for making time to join us. I can see we are already 30 participants in the meeting. So let us welcome Dr. Orlando to moderate and Dr. Mundia to teach us this evening. Karibuni sana daktari.
Thank you.
Thank you, Dr. Lois.
Dr. Orlando?
Thank you very much.
Dr. Mundia, you can just go ahead. Oh, I think he's
back.
Joined.
Hello?
Yeah.
Can you hear me? Yeah, this is Dr. Orlando. I'd like to introduce the presenter for the day, Dr. Danji Mundia.
We can't hear you, Dr. Orlando.
Okay, Dr. Mundia, please proceed. Can you hear me?
From very far, daktari.
Okay, can you hear me now? Wow.
So maybe you need to have a microphone.
Yeah, in a minute. Hello? Can you hear me now? Wow. Hello?
Yes,
Hello?
we can hear you, daktari, only that your voice is very low.
Okay, fine. Then I suggest Dr. Mundia could just go ahead. I'll have it sorted out, then I'll join in.
Karibu sana, Dr. Mundia, please take us through.
Thank you very much. Am I allowed to share my screen?
Yes, you can.
Is it visible anywhere?
No, not at all.
Not at all.
Yes.
Nothing yet?
I think it's sharing. Okay, it's showing us something about a live demo on Zoom. We can now see your desktop.
Yeah, let me go to it now. I hope it is opening.
Yes, it is.
Now, thank you very much, Dr. Lois. And thank you very everybody for availing yourself for today's CME. I'm going to talk about management of cataracts in children, and not so much as to the techniques of doing the pediatric cataracts, but probably to have an idea of the overview of the setup that we need to do for these kind of cataracts. I've realized by going to a few other hospitals apart from my main one that we really are not well equipped to do pediatric cataracts in some of these units. So the aim of my talk today is to see, I hope you can see my cursor.
Yes, we can.
Yeah, my aim is to see how we can move from this point to the point where we remove the cataract in a safe and efficient and of course beneficial way to the kid. So I would like to look at it in this category of levels of care, what we do in the outpatient department, what we do in the preoperative departments. Intraoperative, of course, is the technical part, and of course, immediate and long-term postoperative care. Those are the areas that I would want to look at, so that, and I hope that this serves also as an advocacy for those who really are setting up or are required to set up the units to care for these kind of children. So what do we do for the OPD? As usual, we take history, and for cataracts, of course, there are many areas we would want to delve into. The onset of the cataracts, the family history, the perinatal conditions that surround the cataracts, and of course, the full examination, both for ocular and systemic exams. Then, of course, there's the diagnosis. Some of routine cataracts, of course, don't need a lot of lab works, but of course, we know that there are some areas that you'd want to delve more to actually unearth a systemic condition that would cause the cataracts, because we don't just want to remove the cataracts and leave the kid. Of course, we look at the kid holistically. So there are some cases that, like rubella, homocystinuria, and Wilson's disease, and others, Marfan's, that you'd want actually to go further, either to also consult a pediatrician or do some lab tests so that we can confirm or rule out some diseases. And also, importantly, the outpatient department is also the ultrasound. So because most cataracts would come dense and you can't see the fundus, you'd want also to go and see what is behind, so that you can also give yourself a prognosis of the outcomes of what you're going to do. And of course, to have an aesthetic review so that you can also anticipate the safety of the operation. Just to emphasize on the ultrasound, those are two kids with dense cataracts. The left one is a cataract that would look very naive, and you would go in and remove it. But of course, when you dilate, you see that they are posterior synechial. And in a 7-year-old boy, you would wonder where the acne has come from. So this one actually drives you to think of just more than the cataracts. And we went ahead to do the ultrasound, and you can see what we have. So these are kids that we also queried to have tuberous sclerosis because of the angiofibromas that are on the face. And in the ultrasound, we saw these masses that were throwing some shadows behind them. And we thought they were probably hematomas in the retina. So these are kids I eventually sent to the vitreoretinal department, because I thought there's more than just the cataract. And of course, in the examination, we also see like the right kid who has a subluxated lens. And this helps you also to plan yourself. Are we going to do a plain lensectomy, or are you going to do a sclerofixated lens? So outpatient departments also helps you to plan your surgery. So these are summary of probably of some of the things that you'd want to look at in the when you are dealing with the kid in the outpatient department. And also, like I said, is to help to predict post-operative outcomes. You or consider ocular and systemic commodities, and of course, consider perioperative safety. That's why you look, you'd go to look at these parameters, either in the eye or in the systemically. So the immediate preoperative care, I would say this is what I would do in the ward. Of course, there are kids that would come and straight away go to the wards and they would be done lab works again, especially if the outpatient lab works have expired. You do hemograms, UNEs, the usual, and also depending on what you examine or you suspect of the kid to have systemic problems. Of course, the vitals in the ward, pre-anesthetic review, site marking is very important, especially for kids that have unilateral or cataracts that are not very obvious and dense. You probably would go for the wrong eye if you didn't check. Site marking, dilation of the kid. Again, you would notice if the eye is dilating well or not. Then that one also gives you an idea of, is it going to be an easy surgery or is it going to require like iris hooks? What is the outcome going to be like? And this helps you to plan your surgery. Of course, there are those who are kept on an NPO for some time. And of course, for bigger kids in the ward, we can do biometry, but we'll come back to biometry later in the intraoperative segment. So those are the things that you would want to do in the ward. And most importantly in the ward, I would want to emphasize on biometry and anesthesia. Those kids that are above 5 years that are cooperative enough are better than biometry in the ward. What about intraoperative in the operation theater? What are the concerns that we have? Of course, the biggest in children is the general anesthesia. You have the GA. Do you have the person to do that GA? Are they competent? Do they know how to give the GA in the ocular surgeries? Of course, most of the kids that are, especially those who are comparative, below 14 years, some will be like 5, 7 years, and the very uncooperative, you'll do the biometry in the operating room. And then we will look at the surgery itself in the operating room. So these are set up in the operating room. The first we said is the anesthesia. There is the induction of the anesthesia, which should be safe. And you have to decide, am I going to do an laryngeo mask or am I going to do endotracheal tube? For bigger kids, the laryngeo masks are big and they're not flexible, and they may come into the view into the view and the operating field. So those ones probably would want to do endotracheal tubes. So again, for the GA, there are those kids that would want to come in and out without having to spend a night. That's what we call fast track anesthesia. So the anesthetist should know that they're going to use short-acting agents for the daycare, or if not daycare, for surgeries that you anticipate to be fast. You tell them to use fast-track anesthesia so that the kids do not take long to reverse. And of course, we know that we don't want the kids to either cough when they are being extubated so that they don't increase intraocular pressure. And that is why they are told to extubate when the kids are still deep. And of course, the usual is the oculocardiac reflex. They should know how to deal with that and be aware of that. They should also alert the surgeon when, especially we are pulling on the muscles when you're hooking the superior rectus. We should alert them. They should alert you when they find that cardiac, the pulse rate is going down. So we want to work together with the anesthetist, and they should know. Most anesthetists also know how the surgeon works. There are those who know that you will take a little longer. There are those who know that you will take a little shorter. And of course, depending on the case, you will tell them how much time you expect to take. So the other part in the intraoperative OR is to do biometry. And this is where probably I would want to lay emphasis in my talk today, that in many, even in some private, high-ranking private hospitals, you don't get these machines available in theater. And probably a pediatric surgeon like me would feel very lost if I went to a theater and I didn't have a way of estimating the lens that I'm going to put. So it's good to have these portable keratometers. You can have whatever type. These are two types. You may have the simple ones, or these days I think they are more sophisticated autorefractors. Then you have the A-scan to do the biometry. This picture is just showing us doing biometry in theater, and that is preoperative. Now we ask ourselves, we have those centers who want to do biometry, then go ahead to order a lens. I think this is not possible in a pediatric setup because you don't want to reverse the kit to come again in 2 weeks when you have ordered the lens. So the lenses must be available. So in the theaters, we would ask ourselves what causes inaccuracies in pediatric IOLs, because it's not as easy as it is in the outpatient. And some of the factors that cause inaccuracies, even as you do biometry, you should be aware of this. The axial length and keratometry measurements errors, like you are pressing on the eye, probably you are tilting the keratometer so that you don't get a true axial length, and probably you get a cross-sectional length. So these are the issues that you should be aware of. Poor cooperation during examination and of course, those who are in the ward and you are trying probably also to do biometry. Remember, sometimes they don't fix it well, and they probably would give you a varied results because of uncooperation. We don't know yet what supine position, when you're doing measurements, keratometry, axial length in a supine position, what effect does that have? I don't think we have come across any study that have looked at that, so that we know that the machines that we are given and the formulas that we have given is for an adult that is seated probably upright, but we don't know what a supine position would, how a supine position would affect that. Then even the instruments we are given, the biometry, the keratometers, the A-scans, the probes are not meant for kids. So we are still using the adult made probes for small kids, even when we have microphthalmia. So we don't know again how this affects our readings. Of course, the anatomical differences in adults and kids, and we are using machines that were that are calculated or calibrated to measure adults. And of course, we are using adult formulae. And when we do also the posterior capsulotomy anterior and anterior VT, what effect does that have on IOL position? Does it, and of course, when we put the IOL in a bag, and then we go ahead to do anterior vitrectomy, what effect does that have on refraction? So those are the things that will be in our mind when we are doing. But all in all, we have recommendations of how we can go ahead and select an IOL. And of course, in most literature, you will read about target post-refraction parameters, so that there are so many studies that would recommend what kind of postoperative refraction you'd want, given in mind, reminding ourselves that these eyes are growing and there may be shifting refraction. In our setup, it's always a question, do we give emmetropia at the beginning, or do we want to follow our Western world where we anticipate myopic shift and meanwhile we use correction? Most of our problem lies in the follow-up, so that even when you want to do some correction before they move away from the myopic edge, we don't correct them well. Either they don't wear fake glasses, they don't wear contact lenses, they are not wearing glasses as we expect them to do, and sometimes they don't come at all. So sometimes we get tempted to actually give emetropia so that they go away with good vision meanwhile as they grow, and then probably come back when they can't see in school. But of course, those who can be followed up, it's good to do an IOL that we anticipate myopic shift. So those are some of the recommendations. There is Enyada who recommends a factor of 7, that if a kid is 1, you undercorrect so that you have a refraction of +6 at the immediate post of refractive, within 1 month of surgery. If there are 2, you give 5 to have an addition of 7, a sum of 7. That's what is called a sum of 7. So this is 1 + 6 is 7, 2 + 5 is 7, 4 + 3. That is a simplistic way of looking, but of course there are people who have worked at the formulas, and the mostly accepted probably method is Trivedi and Wilson, who have again recommendations, which of course you can hang them on their OR and probably read them. Again, these are studies, and of course we have seen a lot of formulas that have been used. It's recommended that for short eyes, we use Overview and Holiday 2. For moderate eyes, 22, 26 millimeters of axial length, we use those formulas. And of course, there are those people with high axial lengths. We can do SRK 2 and Holiday 2. So those are some of the recommendations. And of course, Dan, who also worked a lot with these kinds of kits, gave a simplistic way, and probably most of our theaters we see these formulas, is a simplified way of saying, why don't I group these kids instead of cramming all this, and said 0 to 1 years, I can undercorrect by 6, and probably hit a 6 diopter undercorrection. 1 to 4, if I undercorrect by 3 diopters, probably I'll be able to hit a +3 refractive error after the surgery. And of course, 5 to 12 years. That's a simplified way. But there is this formula, which is a simplified SRK, the original SRK formula, where you can say, I want, and this even is usable used in the adults, where you want to probably attain a myopia in monovision. So you can say, this is the refraction I want. I want +2 here, or +6. And this is a formula. This is a constant. This is the IOL that I have done biometry and has given me for metropia. And the question is, what IOL am I going to insert here? The I. So this is R is the desired postoperative refraction, +6, +4, +5, whatever the kid, according to the age of the kid. Then you slot in the rest of the parameters and get you what IOL you're going to insert to get the refractive formula. So intraoperative, that is probably a lot of things we do, but of course it's good to anticipate the myopic shift. In my case, I do anticipate myopic shift, and I use those formulas a lot. This is just to emphasize that we cannot afford to reverse the kid only to buy an IOL. So if you are planning to have a pediatric cataract unit, it's good to plan to stock IOLs, and stock IOLs in terms of, are they foldable, are they rigid, and a wide range of powers from +1 to 35. You could actually also want to put a sclerofixated IOLs with various powers, iris closed with various powers, and of course those who are doing phakic IOLs, of course, again with various powers. So this is important, that we know that we need to stock IOLs so that we don't have to reverse the kit to do that. In a few cases, of course, where the IOL is not available in stock, you may have to reverse and seek to stock it. This is about interop. I am not going to delve into the area of specifics in terms of technique on how to remove the cataracts. I think we have done that before, and probably it will come in another lecture. But what I want to emphasize here, of course, for those policymakers is we need a good microscope, and we need a cutter here, because in most, as we used to see, this is very important in pediatric cataract. Otherwise, we'll add into trouble, and we may not have done much if we just remove the cataract and insert an IOL. So this is the first page showing just how we do our scleral tunnel, how we do our capsulotomy. This is doing lens washout or lens aspiration. We can do that manually, or you can do that with the cutter, the aspiration port. This is an IOL being inserted. And of emphasis is where we do posterior capsulotomy and anterior vitrectomy. This can be done through the corneal port, if especially you have unfoldable IOL that you can displace. But for rigid IOLs, you may not be able to displace the optic for you to reach the posterior capsule. So you can do that through that route, or you can go past planar for kids that we'll see later. The selection of when you do anterior route, or you do through past planar. And of course, a lot of people are rarely do the past planar because of the risk of retinal detachments. But these days we have safer methods. We have even trocars, and our vitreoretinal surgeons are happy to let us use their trocars. So when do I do posterior capsulotomy? Through the anterior cornea route, and when do I do through the past planar route? Of course, I have to have a well-dilated pupil with a big and adequate capsular bag. There are those kids with small bags that once you place the IOL, it is so well snugly fitted that you cannot even displace a millimeter of it. Of course, you have to have a foldable IOL. Don't tilt or displace a PMMA, otherwise you tear your capsule, or even stretch your zonules to have disease dehiscence. If I'm anticipating to put an IOL in the sulcus, I can as well, ahead of that, do posterior capsulotomy and anterior VT, because anyhow I will place it in the sulcus. Past planar, I go for small people that are not dilating. I cannot see how I'm going around the optic. Of course, I said small capsular bags, large zonules. I don't want to stretch them anymore. Microphthalmic kids, especially with smaller capsular bags. And of course, when they come for secondary past planar capsulotomy, because the IOL is snugly fitted in the bag or wherever it is, and you cannot displace it. So in secondary past planar capsulotomies, I would go past planar route. I hope I'm still audible.
Yes, you are. Yes, you are, Daktari.
Otherwise, I'm feeling like I'm alone.
You're not alone. You have 97 people watching you, 96.
Okay. Now, the other step I ask myself, and this is probably you'll find this in literature, is whether you'll do the two eyes at the same time, or you'd want to space them. I know there are countries like Egypt who have outlawed actually simultaneous surgeries. For myself, I do one eye, and I assume that is a different patient. I would pad, even put a shield, and move away as if I've finished with that patient, and come back for the second eye, quite new gowns, new gloves, new set of instruments, and so to minimize infection in the OR, because it is infection that actually bars people from doing the simultaneous one. So whenever possible, it's good to do a simultaneous surgery. I have seen a kids done one eye, and because they can see with one eye, they just go away, only to come years later, and probably they came at a good pre-amblyopic age. Then they come later is when they're going to school, and they say they can't see with the other eye and one eye. And when you do that cataract, surely they are so deeply amblyopic. So I've seen kids that have absconded from doing the second eye, and that's why probably we would want to do simultaneously. Of course, it is faster and cheaper for the kid if you are doing one GA. And of course, you better manage amblyopia. If you do one eye and then they disappear, by the time they come for the second eye, and probably it was a better eye at surgery, it will be so amblyopic. So I find it easier to do both eyes. But of course, this, as I said, needs strict infection control methods so that you minimize on intraop infection. I routinely give intraocular Zinacef, or these days moxifloxacin. Children, we do subtenon depots because of postoperative inflammation. And when you're doing bilateral or simultaneous surgery, you must do biometry. Otherwise, you can't guess twice. You don't want to guess twice, that you'd want to put this lens and in the other eye, you're still guessing. So when you do biometry, then you're allowed actually to do simultaneous surgeries. Kids inflame a lot. So we do frequent steroids, intra-op and even post-operative, of course, with antibiotic cover. I would want to talk about cycloplegia. There are people who actually refer kids with cataracts and already they have atropinized the eyes. Those kids I cannot operate immediately. When you atropinize the eyes, the cycloplegia and the mediasis take such a long time that there is posterior synechia and IOL capture by the time the atropine is wearing off. So I prefer using short-acting cycloplegic agents like cyclopentolate or tropicamide. Postoperative, of course, we do retinoscopy. I do cycloplegia and mediasis when they come in the first week and the first month, when they're still doing cycloplegia, the pupils are dilated and you are able to do refraction so that you can very early know what you attained for your postoperative refraction. And of course, I'll do in 1 to 2 weeks the first follow-up, or they come at 4 weeks. And this is a time that I would want actually a definitive one, because these are 4 weeks is when I prescribe glasses and of course start patching. Our follow-ups are very poor in Kenya. This is a study we did in 2012, and you can see by 1 year, we have all less than 30% the children coming back to us. So, and that's why we think, do you need actually to do emmetropia in the first part, or do you want to do follow-up and do follow-up for myopic shifts? That's a question that is going to be with us for some time. Of course, in repeated refractions, we have to have a refractionist who doesn't tire to be told, you did this refraction 2 weeks ago, repeat it, or you did this refraction 1 month ago, do again, and they should have a reason. We should give them a reason to do that. Otherwise, some of them, you come back and telling you that they did 3 months, and the kid can continue with the same glasses. You say, no, this is an eye that is growing and changing, and I want to see what is new. Amblyopia therapy is a must in a setup that you are caring for these kids. I always say, if you can't do amblyopia therapy and follow-up, don't operate on a kid. Just send them to where they can be operated. Otherwise, people are happy to remove the cataracts and probably not know what happened to the refraction of those eyes. And we change glasses. You have to talk to the mothers and the fathers and tell them they are going to break glasses, yes, and the doctor is going to require you to change glasses. And of course, where you have refractive surprises, you may have to exchange eye well. Is somebody asking a question? Hello? So for kids, hello?
Nobody is asking a question. Somebody had unmuted their
okay.
microphone.
So we advocate that we follow up these kids well above 10 years, because we know amblyopia can be reversed or can be treated up to 10 years. So, and they can fall back, they can slide back to amblyopia up to even 11 years. So it's good to follow them well above 10 years. As you follow them, of course, you manage late complications. And of course, we need a good person who can do children's visual acuity and low vision where it is needed. So for those who wanted to set up, probably again to emphasize, you do a good cataract, but you never know what vision that kid has if you don't have the right methods and the right persons to do visual acuity. And probably that's why I'm bringing this chart before you. This is in Kikuyu, where they are lucky to have a low vision department, where they have various visual acuity charts for various age groups. These are preferential Cardiff. You can have layer numbers, layer symbols, and of course, low vision resource center apparatus. So these are various methods. There are even those who pick bits that are called 1,000, 100,000. But you also have to have a way of converting this to a known method of a known decimal of vision. So there are conversion figures, especially in the layer charts and Cardiff, but 1,000, 100,000 is difficult sometimes to convert and to tell what kind of vision they have. But of course, even using targets that they can fix it on, you are able to tell whether one eye is weaker than the other, and very early start amblyopia therapy. On the follow-up, of course, there are things you'd want to tackle. Here I'm showing 2 cases of wood leaks, where we say that children's eyes are not small adult eyes. They behave differently. We know the scleral and the corneal elasticity is different. So it is important that when you do surgeries, you close the ports well, whether it is the sclerotomies or the side ports in the cornea. So here we have a picked people, and you can tell that this postoperatively had a leakage in the paracentesis, or there is a vitreous wick going through that part and causing leakage. This is a sclerotomy, a scleral tunnel that probably was left loose, or what people would call sutureless. And in children, this is not forgiving. They will either cough or rub the eyes. You are not sure what they are going to do. And soon you are going to have a prolapse of the iris, which may be very difficult to repair. Some of the also postoperative complications that you may want to manage is phimosis. This is a posterior capsule opening that has phimosed to a smaller bit, and you can see a lot of PCO. And this is a case of telling you, even when you do posterior capsulotomy, you still need a big, wide capsulotomy and a good anterior vitrectomy. we have seen people who scratch the posterior capsule with a needle, and if this is what happens even with a cutter, you'd wonder what would happen of a scratch, of a needle scratch in the posterior capsule. Probably one would be treating themselves, but they opacify very soon. Children's in 2 weeks, the opacities have set in. This is what also we see a lot. These are good posterior capsulotomy, yes, but of course we have some lens matter, this ethnic pearls forming and forming on the anterior vitreous face, and you need to remove this. And that's why probably you need to follow up on these kids. Now, I would want to put some emphasis here. This is what we get a lot referred from the periphery, and especially in centers where they do cataracts for any reason, either traumatic or non-traumatic, and they don't have vitrectomy. So this is a patient with corneal perforation. They have been repaired, and lens washout has been done. And this is an IOL, which is magnified here. This is an IOL that probably was put in the sulcus, and the patient left. But of course, there was vitreous wick or fibrin forming towards the repaired cornea. And this will fibrose and pull things towards the perforation. So these are thick bands of tissue coming to the wound and lifting the IOL off the sulcus. So that's an IOL. And this kid, we have to come separate the thick band that's coming to the wound and probably either replace the IOL. It's a very difficult case. So I advocate that if you don't have a cutter and you have a perforation out in the periphery, probably it is safer to just close the perforation and leave the cataract untouched, because probably just behind that cataract is a PC tear and vitreous will flow out. The cataract probably would hold on until we refer this kid to a center where we can do the cataract operation and posterior and anterior capsulotomy. This is another band, another case similar. There's corneal perforation. There's, of course, repair, good repair. But of course, there was lens washout and vitrectomy was none done. And you can see what happens to a thick fibrous band that forms from the vitreous cavity to the wound. So it's difficult when they come to us when they are like this. So if it is possible, because sometimes it's not possible to avoid the ruptured lens washout, if it is possible, just leave the lens alone, just do your perforation and let somebody to do the lens washout and anterior vitrectomy in a setup that has such facility. Thank you.
Thank you very much, Dr. That was very informative. We'd like to take questions. We have a couple in the chat section, which I will read out to you, and maybe you will go through all of them and then you will answer all of them at the end of the session. So we have somebody called MM requesting you to share the PowerPoint after the presentation to our emails. I think this PowerPoint is recorded, and it's recorded and uploaded in the OSK website or COEXA website. So that should be sorted out. Then we have a question from Helen Roberts, who says, are there pediatric formulae available for biometry? I think Dr. touched on that, but you will answer her. What is the youngest age that you would insert an IOL? That is Zara Rashid asking. And we have another question from Helen Roberts that says, is there any value doing objective retinoscopy on the table? We recommend a good look with the indirect on the table. Then Dr. Frank Nyakawa is asking, he says it's a wonderful presentation. For dense bilateral, when do you operate? And number two, when do you operate for unilateral dense cataract? Then Dr. Helen Roberts again is saying, please talk to us about postoperative complication of glaucoma in congenital cataract surgery, the risks and the management. And Zara is also asking, it's important to ensure that optometrists have good retinoscopy skills, have the ability to assess children's vision with pediatric charts like Cardiff cards, Layer cards, who can guide on amblyopia therapy and low vision therapy if you're going to manage pseudophakic and aphakic babies. Let me finish that. A pediatric contact lens fitting service would be beneficial too. Then I think the last one says, there are some children who have been left emmetropic but have ended up with minus 15 diopters by the time the child was 8 years old. So those are the questions in the chat. Dr. Mundia, maybe you can respond to them. I saw you noting them.
I'm doing that. Sorry. You answered for me the first one, PowerPoint. I think Wesley has even asked me for that, for it. I think it is available. Now, you can hear me?
Yes, we can.
About retinoscopy on the table. Yes, you can. But what does that tell you? Because you're not going, even when they come the first week or 2 weeks, I don't give glasses. I give glasses on the refraction in a month. So you'll still need a retinoscopy in 1 month to decide whether you give what correction you are going to give. It will give you a good idea of what you have, and the IOL probably you do, but it will not negate that you will still do a retinoscopy. And you need a very good refractionist or optometrist to do this, because I don't take the kids for EOA every time. If you have a good person who can do that in the outpatient, it suffices. But I think yes, you can, but I don't see how it will inform you on the subsequent retinoscopy. On the how to manage glaucoma, of course, especially in such eyes that have shown you that have complicated cataracts, very small eyes, and even sometimes you have surprises on a very quiet eye that develops glaucoma. It's difficult situation to manage pseudophakic glaucoma in children, but they are there. And of course, there's medical aspects of it. And Sheila will tell you probably should go for the AMED or devices very early, because when they are pseudophakic, probably you have gone through the superior conjunctiva, you have messed up with it, is fibrosed. Probably the option you have when they are not medically controlled is a valve device. There was a question about formulae. I think we touched on the formulae. It's a practice actually all these formulas is when you practice, you realize that even when I wanted to give a +6, I always get a +3 postoperative. And probably you tell yourself, probably your biometry or your method of biometry gives you an error, and probably you need to also to correct more. So this, after some time, you'll be able also to judge for yourself what formula and what correction amounts you want to do. How young should I do a cataract? As young as I can. Cataracts you can do even as young as 2 weeks, as long as you have the right GA, you have the right instruments. But these kids probably you'd want to leave them aphakic, and that's where Zara comes in. When I leave them aphakic, I give them to her because they need contact lenses for the first few months before you put a secondary IOL. But I qualify that because personally, I feel that it's better to wait for 2 months and put an IOL than leave a phakic and probably come to try to put a secondary IOL, because when you're coming for the secondary IOL, you may not have the luxury of having a bag, and the posterior sinic here, you have to dissect the sulcus is much more difficult when you're doing a secondary IOL than a primary IOL. So whenever possible, I would want to put an IOL, and personally, either because of the GA or the size of the eye, I would wait for 2 months, or when they are 5 kilograms and above, to put an IOL. I try to put an IOL in every kid as much as possible. Dense bilateral cataracts, of course, and I don't have timelines for dense bilateral cataracts. I think, unfortunately, we get our kids very late. We don't have the luxury of getting kids in their first month of life. So they will come, either they thought it's not necessary, they thought this is our family issue. So they come, and if I look at my at our study that we did 2012, I think our median age was about 3 to 5 years. So these are kids that you will do them as soon as they arrive. In fact, we had a policy in Kikuyu when we had CBM that we admit any kid that comes with cataract. Unilateral cataracts, of course, you do as early as possible. For dense cataracts, I say if a kid was born, is congenital, is too young, 2 weeks, anesthesia may not allow, I go for 5 weeks, for 2 months. But of course, unilateral you'd want to do early because of the risk of amblyopia and the difficulty in treating the amblyopia. Contact lens, Zara has well dealt with that. That was a comment. Now, about emmetropia and myopic surprises, this can happen to anybody. I've seen a kid who we started very innocently at +3 when they are first month, and about 8 years later they have -20. These are very unusual cases that you not do a lot about. But the question that we ask ourselves is, if in the time that you're doing amblyopia therapy, in the time that the kid is very stubborn, the mothers are very stubborn, these small ages that they would want to ask you, this kid, can they really wear glasses? And actually sometimes they say no. These are the kids that you feel like I could leave emmetropia and deal with myopia when they are older, and especially out of the amblyopic age. But of course, if you have a good understanding family, you have your chances of good follow-up is good to leave hyperopia than deal with myopic shifts. There are always surprises in this. You will leave. There are kids that have they don't have those formulas in their head. They just go anyway. And there are some people who have refused to move from +6. You give a kid +6 and they are not moving from there. And you'd want actually also that they have that shift. So some of them are unpredictable, and you have to deal with such kids. I think those are what I had.
Thank you. We have 2 more questions, and then maybe we can wrap it up with the sponsors giving a short talk. We have a question from Dr. Godfrey Nyaga saying, would you advise an ophthalmologist in the periphery with corneal perforation with ruptured lens and vitreous loss? Any benefit from sponge vitrectomy and using air? Then we have a question from, we have a comment from Dr. Kimani saying, very clear, informative and concise presentation. Thank you, Dr. Mundia. And yeah, Dr. James Bett is asking, corneal lacerations with traumatic cataract, should we implant IOL on same sitting? And he also commends you for a great presentation.
Thank you for the commendations, and Dr. Nyaga, yes, you can do sponge vitrectomy, but I would actually desist from putting an IOL on a kid that I don't know where the vitreous is. I would desist because once they have one, they're going to have inflammation, they're going to have vitreous, and some of the lens matter. You can bet that this IOL is going to be displaced. They are going to mess up that eye. Those are the kids that come with flat ACs and very fibrotic capsules. I would probably, if there is vitreous in the wound and I want to close that wound, of course, you have to remove some of the cortical matter. You clear, a sponge clear some of the vitreous, but I would desist from putting an IOL and send this kid, just know that you have not cleared enough of the vitreous. Assume that you have not cleared the vitreous and send to a center where they can do. Because I think the danger here is to assume that you have cleared enough vitreous with a sponge and let the kid stay for too long before you clear the vitreous. So I think that one also goes to the second question, implanting an IOL. I would desist to implant an IOL after a laceration if I'm not cleared the vitreous well. Of course, if there is no vitreous, there's lens washout, you have done your lens washout, don't touch the posterior capsule. Just send you can put an IOL probably because they may delay coming to us for vitrectomy and good lens washout. If you do a good lens washout, you have posterior capsule, leave it alone. If you don't have a vitrector, and send the patient to a place where they can do early posterior capsulotomy. Otherwise, when it is students, again, we have to go with scissors. We have to borrow scissors from the vitreoretinal teams to cut it because even the cutters sometimes don't cut those kind of capsule capacities. I think the message here is desist from putting an IOL if you think remotely that there is vitreous in the AC. Thank you.
Thank you, Dr. Mundia. We have a comment from Dr. Helen Roberts. This seems to be a very interactive topic regarding the age of surgery. She says, if the child is blind, yes, the answer is operate as early as possible. I think one has to use the near and functioning vision as a guide if the child is not blind. Earlier surgery seems to be more closely associated with glaucoma, which is very difficult to manage. And loss of accommodation needs to be considered again if the child is not blind. I don't know whether you have a comment on that.
Well, her question deals with if they are not blind. That probably means that a cataract that are not very dense. And we have seen patients with probably developmental cataracts that probably we would want to buy more time. But when the kid is, of course, bilateral, there's school of thought that if they are bilateral, they are very young, you are not risking unilateral amblyopia. Probably you wait, and these are the kids I'm saying I wait up to two months. But of course, if they are unilateral, I would probably do it and leave it aphakic and put contact lenses, but go early.
Okay, thank you so much, Dr. Mundia. I don't know if Dr. Orlando made it back.
Can you hear me?
Would you have any comments on today's topic? You are initially the moderator.
Can you hear me?
Yes, we can.
Yeah, thank you very much, Dr. Mundia, for the very nice presentation. I think you've covered most of the areas I would want to cover. So good job. Thank you.
Okay.
Dr. Orlando.
Thank you.
Thank you so much. It's been a great evening. We'd like to thank our sponsors, Allergan, for sponsoring today's CME. At this point, I'd like to welcome the presentation from our sponsors. I would kindly request that we all hold on because I'll be bringing to us the announcements after the presenters give us a few words.
Thank you, Dr. Louise, and thank you for giving me this opportunity to present to your audience. I would kindly appreciate if you could enable me to share my screen. Can you hear me, Doctor?
Yes, Ruba, we can hear you.
Okay, Doctor,
But we
please,
cannot see your
can
screen.
you enable me to share my screen, please? Because
Somebody-
for now, can you make me the co-host so I can share my screen, please?
Yes, somebody is doing that for you.
Okay, thank you. Thank you, Doctor.
Perhaps Dr. Mundia can stop sharing his screen.
Okay. So I just would. Okay. Is my screen visible, please?
Yes, we can see your screen, Ruba.
Okay, so I'm going to be very quick. My name is Ruba El Basha. I am the medical scientific liaison for PHA, the official representative of allergy in the region, including Kenya. Today, I'm going to present to you the principles of treatment of dry eye disease, which is under the therapeutic areas of allergy. So this slide shows you in summary the causative factors or risk factors that are correlated to dry eye disease. These are in gray. And the internal circle is the internal pathologic mechanisms that are also involved in dry eye disease. So these are the four main components of dry eye disease: the tear film instability, the hyperosmolarity, the apoptosis, and the inflammation. Current treatment, they aim to promote exit from this internal cycle of pathologic mechanisms. And we're going to talk about how treatments address each of the four areas of dry eye disease. So different therapies act on different points in the vicious circle. First of all, we have the environmental strategies that tackle tear film instability and tear supplementation, some devices for tear retention, stabilization of the lipid layer for patients suffering from meibomian gland disorder, hypotonic artificial tears and osmoprotectants that deal with hyperosmolarity of the tear film and with apoptosis. And for inflammation, we have also the new role that was confirmed for omega-3 fatty acids. Serum for inflammation and apoptosis, and anti-inflammatory therapy for inflammation. So artificial tear substitutes, as you can see, are among the first-line treatments for dry eye disease. So these are examples of polymers that are included in artificial tears. Polymers, they provide lubrication, then they enhance viscosity of the tear film, they increase retention time, and they promote tear film stability. You see we have 2 or 3 classes. We have the cellulose esters, the vinyl derivatives, and we have also the third category, which is the viscoelastic agents. When we talk about cellulose esters, they are water soluble, they are viscous and highly mucoadhesive, and they are also stable, and they are tolerated by the eye and unaffected by light. And solutions of pure methyl cellulose do not support bacterial growth, so they are relatively stable, and cellulose esters, they mix well with other polymers such as hyaluronic acid, so they can easily be mixed with other products included in artificial tears. Vinyl derivatives such as polyvinyl alcohol, polyethylene glycol, and propylene glycol are water-soluble synthetic polymers that prolong retention time. So this is how they act in the stabilization of the tear film. And viscoelastic agents are found in the extracellular matrix, and they are involved in natural wound healing. So they are lubricating and bioadhesive with viscoelastic properties. And these are the hyaluronic acid, for example, the hyaluronic acid and the chondroitin sulfate. Now let's start with treating tear film instability in aqueous deficient dry eye disease. You all know, doctors, that there are two kinds of dry eye disease, the aqueous deficient and the lipid deficient. Addressing tear film instability in aqueous deficient dry eye disease, artificial tears, they form the foundation of many dry eye disease regimens. They increase tear volume and stabilize the tear film, and they can be hydrophilic, mucomimetic, so they act same as the natural mucin, and they have lubricating properties. And artificial tears, they increase tear volume and stabilize the tear film. So this slide shows results from a large observational study in which patients with a range of disease severities were treated with a carboxymethylcellulose-based product. So these are the polymers. Following 2 to 4 weeks of the carboxymethylcellulose-based product, tear breakup time increased versus baseline in 3 categories of severity, whether it was mild, moderate, or severe dry eye disease. So carboxymethylcellulose had a positive effect on tear film stability at all levels of severity. So if patients have aqueous deficient dry eye disease that is confirmed with a Schirmer test that is below 7 millimeters, an aqueous-based artificial tear formulation may be sufficient. If symptoms are severe, consider using gel therapy at night. For lipid deficient dry eye disease, so 95% of artificial tears that are sold are aqueous-based. However, most of dry eye disease have a lipid deficiency components. So the majority of cases have an element of lipid deficiency, as I said, yet the most common treatments do not meet their needs. That's why some of the patients, while being under treatment, they still suffer from symptoms. Currently, the mainstay of dry eye treatment is topical artificial tear replacement drops. However, partly because of the lack of a lipid component in such lubricants, they usually provide only very brief relief for the patients. So how do we address tear film instability in lipid deficient dry eye disease or meibomian gland dysfunction? We should put oil-based emulsion formulations that contain carboxymethylcellulose, which is combined to castor oil, or propylene glycol, which can be combined to other lipids. So these will replace natural lipid layer and limit tear evaporation. And lipid-containing formulations can lead to improvements in tear breakup time compared with baseline or compared with standard therapies. So if a patient has lipid deficient dry eye disease that represent with red lid margins, blocked meibomian glands, tearing, burning, itching, and stinging, we should recommend a tear with added lipid and provide recommendations on lid hygiene. So these are formulations that exist in some of the products of Allergan. So you can cover lipid deficiency with our products. We can recommend also the following: to use hot compresses morning and evening to do lid massage with closed lids. We should avoid baby shampoo and we can apply topical antibiotic to lid margin, and omega-3 fatty acid oral supplements were also recommended. And nowadays there are new formulations of artificial tears that contain omega-3 fatty acids in the formulation of the eye drops. Treating hyperosmolarity, which is the second component of dry eye disease, we know that normally cells, whenever they are in contact with a dry tear film, they tend to release their intracellular water and they become dehydrated. But the normal tendency for the cell is to restore its original volume by intaking surrounding solutes. And by taking these salts or surrounding solutes, the cells become stressed because these salts are not adequate to the functioning of the cell. So this will lead to stress and to apoptosis and to death of the epithelial corneal cell. So in response to a hypertonic environment, which is a dehydrated tear film, cells take up inorganic ions, and this will eventually lead to cell damage and death. The traditional approach was to correct hyperosmolarity by using hypoosmotic tears. However, they cannot address hyperosmolarity adequately because osmolarity generally returns to original level within 1 to 2 minutes after installation of the hypoosmotic eye drop. So they proposed a solution for this problem of hyperosmolarity by adding in some of their eye drops, what we call osmoprotectants. So osmoprotectants, they are compatible solutes, and they help the dehydrated cells gain back their original volume by also being compatible with the cell functioning. So they do not lead to apoptosis of the cells. They are taken up by cells, they restore cell volume and stabilize protein function. These are examples of what we call osmoprotectants: the erythritol, the taurine, the trehalose, the glycerol, and you have also the L-carnitine. If you look at them, so this table shows properties of osmoprotectants that are included in dry eye disease therapies, which are artificial tears. Erythritol and L-carnitine, they reduce inflammatory mediators and corneal epithelial cells. And trehalose protects against desiccation in human fibroblasts and corneal epithelial cells, and it protects also against apoptosis of the corneal and conjunctival cells, and that was shown and proven in animal models. Erythritol, taurine, glycerol, and L-carnitine, they proved to improve cellular function in studies where cells or where epithelial cells were exposed to hyperosmotic stress. So to protect against hyperosmolarity, we should consider a dry eye disease therapy with osmoprotectants that protect epithelial cells. So there are commercially available treatments.
Bacha, Ruba.
Yes.
Sorry to interrupt you. Are you able to summarize? Because this usually is like an after presentation.
Of course,
the presentation could be very long.
Yes, I will make it very, very fast. So I was told that I was told that I have 15 minutes. So I guess I'm still within the timeline. However, I will try to make it very quick.
I'm kindly cutting short your 15 minutes because we'll have everybody signing out and then we will not be productive. Yeah.
So we can also treat epithelial damage, and here the role of carboxymethyl cellulose in treating epithelial damage. For treating inflammation, corticosteroids, oral tetracycline, and topical macrolides Topical cyclosporine A also was an option. And the new strategy for treating inflammation is having omega-3 fatty acids in the formulations. So different therapies act on different points in the vicious circle of dry eye disease. And the range of products of Allergan for the treatment of dry eye disease, they deal with each of these components of the vicious circle. Adding to that, the purite is the preservative that is used in the artificial teeth of Allergan, and purite as a preservative is better tolerated and less toxic to the eye than benzalkonium chloride when combined in brimonidine solution and when combined with other products. So in summary, the overall goal of treatment in dry eye disease is to improve quality of life. To promote exit from the vicious circle, we need to address the central mechanisms, again, tear film instability, hyperosmolarity, apoptosis, and inflammation. In lipid-deficient dry eye disease, make sure that the artificial tears contain a lipid component, and artificial tears with a lubricant and osmoprotectants can protect epithelial cells from tear film hyperosmolarity and subsequent apoptosis. Thank you. So I hope I was fast, and thank you for your attention, and look forward to have other opportunities with you.
Thank you, Ruba. Maybe we should give you a longer opportunity so that you can take us through the management of dry eye in a different presentation. Otherwise, I'd like to thank everybody for joining in today and for staying on 16 minutes into your time. Thank you so much, and kindly bear with us for taking up the extra minutes. I'd like to bring us some few announcements before we can wrap it up tonight. So kindly bear with us. COEXA fellowship exams are open for application. So if you've not sat your COEXA examination, or you know somebody who has not sat their COEXA examination and they'd like to become COEXA fellows, kindly encourage them to apply. The deadline is on 20th of May. And please get in touch with the COEXA office for details on how to apply and the monetary implications to it. This year, the exam will be in Kigali, Rwanda. The 9th annual Congress for COEXA, the early bird presentation is, the early bird registration is open. It's scheduled for 21st to 23rd of September this year. So kindly get in touch with the COEXA office so that you can register and get the early bird offers. And also submit your abstracts for presentation in the 9th COEXA Congress that's coming up in Malawi. Dr. Mutie, I don't know if Dr. Mutie is in, has brought to our attention that all OSK members are reminded of the annual conference that is scheduled for 25th to 26th of November this year in Kisumu. And all the categories that were there in the previous conference are still there. So get ready your photos, your abstracts, your studies, and your cases for presentation during our annual conference later this year. And nearer dates is that we have a NO conference. NO stands for Kenya National Ophthalmic Workers Conference. It's coming up in next month, 16th to 17th of June at Nyali Sun Africa Beach Hotel. The registration is 4,000. Please get in touch with Dr. Mutie in the COEXA office to know how you can go about in registration and presentation of your abstracts. Unless Dr. Kalu has something else that we'd like to announce. Dr. Kalu, are you there?
No, I don't have any announcements. I think they are all done. Just clarification for the NO conference. We'll be posting the communication on our WhatsApp notice. So go there and look at the the notice to get the email address to where you can send your abstracts if you have any, and any further communication. If any clarifications are required for that, kindly get in touch with, I think, Dr. Gishangi. I think Dr. Gishangi for further communication.
Dr. Gishangi.
Yes.
Okay,
Otherwise,
thank you so
don't
much.
have anything.
Thank you so much, Dr. Mundia, for the great insights in your talk today. Thank you, everyone, for joining us. We'd like to call off today's meeting. Have a great evening, everyone. Thank you.